Fibroids are the most common benign tumor of the uterus. They are also called as myoma, leiomyoma or fibroma. Hi friends, this is Dr. Rajeshwari Reddy. I'm an obstetrician, gynecologist and a laparoscopic surgeon from Hyderabad. So today we will discuss about fibroids. First, let me tell you some good things about fibroids. Most importantly, it is a non-cancerous tumor. It is extremely slow growing and not all fibroids need to be treated. The incidence of fibroids is pretty high, with 20% of women having fibroids at the age of 30 years. It is most common between 35 to 45 years, out of which 50% of them are asymptomatic. So, most people when they are diagnosed with fibroid do not usually have any symptoms. Why do people get fibroids? The cause is unknown. Maybe it is hereditary, as in if your mother or your grandmother has it, then you're more likely to have it. Or it can be estrogen dependent, as in early menarche, late menopause, obesity, and people who have never had children. And also it is common in people who take alcohol or a lot of red meat. So fibroids can be single or they can be multiple. Depending upon the position of fibroids, they are classified as intramural. Intramural is the most common type, accounting for about 75% of fibroids. So this is like in the muscular layer of the uterus. Next comes the subserosal layer, which is 15%, which is on the outside layer of the uterus. Next comes the submucous. Submucous is inside the uterine cavity, which is like inside the lining. This is about 5%. And cervical fibroids contribute to 1 to 2% of occurrence. The size can vary from very small, few millimeter, appearing like seedlings, to a fully pregnant state. So it can be as small as a millimeter to weighing a few kgs. As I explained earlier, 50% of patients are asymptomatic, but the most common symptoms are menorrhagia. Menorrhagia is heavy bleeding where the cycle is constant, but people complain of heavy bleeding, as in they might just have 5 days, but still they keep passing clots or have too much bleeding, or they might have prolonged bleeding, as in if they have a 5-day cycle may stretch to 8 to 9 days. They may also have dysmenorrhea, which is painful periods. And fibroids also contribute to infertility, repeated abortion, lower pain abdomen, distension of abdomen, sometimes lump in the abdomen, or it may also cause pressure symptoms, as in increased frequency of micturition or some symptoms of ureteric compression when the mass is very big. It can also cause repeated infections or pyelitis. Symptoms need not necessarily be there in correlation with the size or the number of fibroids. The diagnosis is mostly done by a routine ultrasound. People come for health checkups, just have a routine ultrasound, and turns out that there is a fibroid. Or sometimes people get an MRI done for some other reason and fibroids become a coincidental finding. But when people come with complaints, then our mode of diagnosis is by ultrasound. So what are the complications of a fibroid? So once the fibroid is there, we will be following up with the patient regarding the size of the fibroid and looking for changes or how fast or slow they grow. They can have cystic degeneration where the center becomes soft and necrotic. There can also be calcific degeneration where calcium deposits happen in the fibroid, and this is also called as womb stone. There's also red degeneration, which is usually seen in pregnancy or puerperium, and this is a pretty painful condition. So let's look at the treatment for fibroids. As I already explained, not all fibroids need to be treated. Many a times when it is a coincidental finding, as an ultrasound or in an MRI, we just leave it at that. Not all fibroids need to be treated. Generally, minimizing the blood loss is the main goal of our treatment. So when people come with excessive blood flow during menses or pain during menses, we manage them with tranexamic acid, ethamsilate and mefenamic acid, or a combination of these, which help in decreasing the pain and the blood loss. There are no medicines to completely cure fibroids. So, when is a surgery indicated in fibroid uterus? So, when patients have excessive bleeding as in menorrhagia and excessive intolerable pain, or if the size of the uterus is more than 12 weeks, or there has been recurrent pregnancy loss or infertility, or rapidly growing myomas or subserous pedunculated fibroids, all these need surgical treatment. Treatment depends upon the symptom of the patient, the age of the patient, the size of the fibroid, number of fibroids, location, and the complaint of the patient, as in patient wanting to conceive or not wanting to have a reproductive life or not wanting periods because of heavy menstruation. So treatment depends on so many factors. So when do you do a myomectomy? Myomectomy is a procedure where we retain the uterus and just remove the fibroid from the uterus. So we do this to preserve productive function or to preserve the menstrual cycle of the patient. What is the risk of recurrence of fibroid? This is one of the most commonly asked questions. So people are like, you remove a fibroid, do a myomectomy. So what is the chance of fibroid recurrence? Since we don't know the exact cause of fibroid, we cannot give any treatment to stop the recurrence. But generally, the recurrence risk is 30 to 50%. So, what is this risk of menorrhagia, that is excessive bleeding after myomectomy? This is negligible, between 1 to 5%. What is the pregnancy rate following myomectomy? So, if an infertile couple comes for myomectomy, then they definitely ask this question. So, pregnancy following myomectomy is about 40 to 60%. Of course, depends on many other factors too. So, how do you do a myomectomy? The most popular and effective method is laparoscopic myomectomy. So, what is the rate of conversion of a laparoscopy into laparotomy for myomectomy? It's around 15%. Of course, the skill of the surgeon is the most important point. And then there is also something called hysteroscopic myomectomy. This we do only in patients who have submucous myoma, where it doesn't need laparoscopy and can be removed very easily using hysteroscopy. But having said that, it's always better to do a hysteroscopic myomectomy also under the guidance of a laparoscope. Then there is also another therapy called embolotherapy, which is uterine artery embolization. We usually use this to shrink the size of the fibroid by stopping the blood supply to the fibroid. We also do this preoperatively, or we can also choose to do this when in elderly patients they are not fit for surgery. What is the result of embolotherapy? Menorrhagia improvement is around 80 to 90%, and there might be 60% reduction in the size. Sometimes it also relieves the pressure symptoms. So, when is a hysterectomy indicated? Hysterectomy should be the last choice, and it is preferably only after 40 to 42 years of age, where the patients have completed their family life, symptoms are not relieved by medication, they have chronic anemia which is disturbing their daily life. What are the choice of methods for hysterectomy? Obviously, the first choice would be total laparoscopic hysterectomy, followed by laparoscopic assisted vaginal hysterectomy, or we could also do non-descent vaginal hysterectomy, and of course the open procedure is always there. So I think we can conclude that having a fibroid is not a dangerous thing and does not always require a treatment. And even if a treatment is required, it is not very difficult. It is not a tedious procedure. Whether you go for a surgical method or a medical method, or you go for a embolotherapy, all of them have their own criteria of why we choose a certain method. And end of the day, none of these are life-threatening procedures. Thank you.